So I'll move on to the second case. So this is a female patient again who was diagnosed with gestational diabetes at the age of 25. She had high blood sugars after pregnancy, and again, because she was lean, she was assumed to have type 1 diabetes, and was her insulin therapy that she'd had during pregnancy was continued postnatally. Now she had poor control, and because of that she suffered with multiple microvascular complications related to her diabetes. So she had retinopathy that required laser treatment, she had peripheral neuropathy that required a partial amputation of one of her feet, and she also developed renal failure. And at the age of 45, because of her chronic renal failure, it was noticed that she was getting quite frequent hypoglycemic episodes on her dose of insulin, so they were reduced, and you'll know because of the renal metabolism of insulin that is frequently seen. What was unusual about this patient was that she was able to stop insulin entirely. So now this is some 20 years after having had a diagnosis of type 1 that she'd now become insulin independent. So again, in this patient, a C-peptide was measured, and this was again found to be within the normal range, so indicating, along with her clinical picture, that this is a patient that's still able to make some insulin of her own. And again, the possibility of a monogenic form was thought about, and so she had a genetic test as well, which again confirmed a missense mutation in exon 6 this time, and confirmed a diagnosis of HNF1 alpha MODY. Now, going back one step, we'd again taken a family history of this patient, and again the proband is shown by the blue arrow. So if we go through the other members of her family, she's got an older sister who had gestational diabetes and then was diagnosed with type 2 diabetes at the age of 52. She's on maximal dose of metformin and sulfonylureas, has relatively poor control with an HbA1c of 8.6. She's overweight with a BMI of 30, also hypertensive and dyslipidemic. Her next older sister was also diagnosed with gestational diabetes in her early 30s, and then diagnosed with type 2 diabetes at the age of 37. She's now metformin but with good control, HbA1c of 7.2%, and she, unlike her older sister, is lean, doesn't have any high blood pressure. There are also two younger siblings, both of whom had normal glucose tolerance tests, but the sister was also noted to have quite marked glycosuria during that oral glucose tolerance test. The proband's also got 4 sons. So as we said, an important part of making a diagnosis of HNF1 alpha MODY is to take this out to the family members to see what kind of diabetes they have. And so, as you can see, NM signifies having this HNF1 alpha mutation in the proband. Obviously, it's got a confirmed mutation. So looking at her family members, if we go now to her oldest sister, who had a slightly atypical presentation of MODY anyway, in that she was diagnosed at a much older age, in her 50s, was overweight, hypertensive and dyslipidemic. She actually doesn't have the same type of she doesn't have HNF1 alpha on genetic sequencing, and so this lady has type 2 diabetes, and so she's what we'd call a phenocopy. The next older sister, who had a more typical presentation of MODY, so was leaner and had quite good control, not hypertensive, she did have the same HNF1 alpha mutation as her sister, so again it was another mutation carrier. And now looking at her younger sister, who was noted to have glycosuria but had a normal glucose tolerance test, she does also have the same HNF1 alpha mutation but is currently unaffected, so does not have diabetes. And it's important when you offer predictive genetic testing to patients who don't have diabetes that you explain what it means if a positive test comes back. And the brother, as you might have expected, who didn't have glycosuria, didn't have the mutation. Diabetes screening and genetic testing was also discussed with her 4 sons, and her eldest, at the age of 26, was found to have diabetes, which was a new diagnosis. The HbA1c was under 6, but was he had diabetes based on his oral glucose tolerance test, and he has a mutation. So he doesn't require, or at the time of this family tree being drawn, didn't require any treatment, but from his point of view, he'll have regular follow-up to detect whether his diabetes progresses, and if that does, then he can be offered a sulfonylurea. The two middle sons didn't have diabetes, nor do they have the mutation, and the younger son, like his aunt, is a non-diabetic mutation carrier. So looking at the lessons that we can learn from this case, we can see that HNF1A MODY can be misdiagnosed as both of the common types of diabetes. So within this family, there were patients who had a label of type 1 and those who had a label of type 2 diabetes. And we've already discussed how you might pick out patients who've got HNF1A MODY who've got a clinical label of type 1, but one of the clues in those who've got a clinical label of type 2 diabetes, as Catherine talked about earlier, was absence of insulin resistance, so not being overweight, not having hypertension, not having dyslipidemia, and that might make you question the diagnosis. We've also seen that at least two of these patients initially presented with gestational diabetes, and that again is a reminder to all of us that it's important to ask when you take a family history to ask what their diabetic status was like during pregnancy. And similarly, just to remind you that these patients do have a low renal threshold for glucose, and so might have marked glycosuria at low plasma glucose levels, and that can be a sign of HNF1A MODY. And again, unlike patients with glucokinase MODY, it's important to offer these patients good glycemic control. So in the case of our proband, she'd had a long period of poor control and had developed microvascular complications, which included chronic renal failure, and she actually ended up having end-stage renal failure requiring dialysis and then a renal transplant. So in terms of concluding this particular case, I think a diagnosis of HNF1A MODY has implication not just for the individual but also for their family members. So we've already mentioned that there can be phenocopies, so we shouldn't always assume that anyone with diabetes within the same family has got the same type of diabetes, and you should always offer diabetic family members a confirmatory genetic test. People, relatives who don't have or who aren't known to have diabetes should be tested with an oral glucose tolerance test. And if you are considering doing predictive genetic tests, you obviously need to explain to patients what a positive test means. So in this case, we know that 95% of mutation carriers will have developed diabetes by the age of 45, and they've got an almost 100% lifetime risk of developing diabetes. And any mutation carriers that are confirmed who are non-diabetic, because of their risk of developing diabetes over their lifetime, will need annual follow-up with either an HbA1c or an oral glucose tolerance test. But the advantage to these patients of knowing that they've got the mutation is that they can be screened early, treatments can be introduced early, and they can hopefully have good glycemic control without being exposed to the risk of complications.